All right, our next speaker is Dr. Greg Serrao, who's going to be talking to us about cardiogenic shock, all mechanical circulatory support devices. Please join me in welcoming Dr. Serrao to the stage. Do you know how this is arrow?
Perfect. Okay, thanks. All right. Good morning, everybody. Thanks, Beth, for the introduction, and Beth and Tom for the invite here, and of course, Dr. Sharma, Dr. Kinney, and the rest of the course directors for having me back this year. I've been tasked with discussing all mechanical circulatory support devices in 20 minutes, so I'm gonna do my best. I've divided the talk into 3 sections, each relatively brief because of the time constraint that we have. I just want to talk about the key principles of mechanical circulatory support use. The second will be how we classify shock in general when selecting mechanical circulatory support devices, and then we'll briefly go through all of the devices on the market that we have to choose from today. So just in starting with the key principles of selecting patients for mechanical circulatory support, I think there's 4 main questions that we ask ourselves when seeing these patients. And one is, does the patient have a need for mechanical support? So are they sick enough? Is the patient procedurally safe for mechanical support? And we'll go through the list of things that we try and figure out when we ask that question. Is the patient appropriate for MCS? Meaning, is there a way that the patient can possibly recover if we deploy MCS? And then last is which MCS should be used. And even though probably the majority of my talk today will be focused on which MCS should be used, I do actually think this is the least important and the smallest point that we stress when making these decisions. I think the other 3 questions are the most important. So does the patient have need for MCS? So it really comes down to, are they sick enough? And I've purposely left these 4 criteria as a little bit ambiguous because the truth is that we don't really have enough data to say when someone is definitively sick enough to need mechanical circulatory support. But the 4 main categories of situations where we likely need support is refractory cardiogenic shock, refractory ventricular arrhythmia, refractory cardiac arrest, and sometimes to facilitate an acute coronary syndrome PCI like a STEMI with impending shock. The second question is the patient procedurally safe for MCS? So can the patient tolerate the procedure? So do they have an acceptable BMI? The larger a person is, the higher the risk of bleeding when placing an arterial bore sheath in the groin. So we look for the BMI usually to be less than 40 or ideally less than 35 before deploying these devices. Can the patient tolerate anticoagulation? The vast majority of these devices involve some arterial implementation of the device, which requires anticoagulation to prevent embolism complications in the arterial system. So if someone has a bleeding history, or certainly if they are actively bleeding, this is a relative contraindication to mechanical circulatory support. And lastly, can they handle large bore arterial access? So these devices are so big that they can completely occlude blood flow in the femoral arteries. And if the artery is not big enough, or if the artery is diseased due to peripheral vascular disease, this can be a contraindication and make it unsafe to place these devices. And lastly, is the patient appropriate for MCS? So MCS is not a treatment itself. It's meant to get from one clinical situation to another. And the 3 ways that we can move from one clinical situation to another is called bridge to recovery, meaning we put a support device in, the patient gets better, the support device comes out, and everybody's very happy. The second is we put a device in, and the patient's heart doesn't get better, but we can bring them to the operating room and place durable support like an LVAD or even transplant the heart. And lastly, it would be called bridge to decision, which is when we're unsure if the patient is a candidate for transplant or LVAD, but we put the support device in to try and figure out if they might be and make a decision about whether or not they're a transplant candidate while the device is in. Next, I'm going to talk about classifying shock for the use of mechanical circulatory support, and I'm going to be very brief here and just broadly say that the 2 main things that we use to classify what type of shock someone is in when choosing a support device is by using echocardiography and by using invasive hemodynamics with a right heart cath or Swan-Ganz catheter. And there's 3 main categories that we place people into when choosing which support device we should use, or sometimes even a combination of support devices. And we try and decide if both of their ventricles are sick, if just the left ventricle is sick, or if just the right ventricle is sick. And again, because of the time constraint and because of the focus of my talk, I'm not going to go through these specifics too much, but I do want to highlight that with the expertise of Dr. Kinney, we did just make an app that teaches all of these points, specifically about selecting MCS based on the hemodynamics here. It's called MCS Aid, and it is available for download. And for those of you that are more interested about learning about this particular piece, I highly recommend looking into this. So lastly, we'll go through the available MCS devices. So I'll go through one by one, and I'll talk about how much flow each device gets, how big it is, and the mechanism by which it works. At the bottom of each slide, I've put what I think is the clinical niche for each of these devices. And again, I'll do it for each that we discussed today. So the first we'll mention is the intra-aortic balloon pump. I think it's the oldest and tried and true mechanical circulatory support device that we have. It gives relatively little flow. It augments cardiac output usually by about 0.5 liters per minute. But even though this sounds like very little, sometimes this is enough to relieve people who are just in sort of low-level shock. The device is very safe because it's relatively small French, so it's a 7 to 8 French sheath that goes into the femoral artery. And the way that it works, you could see here listed or pictured on the left, is that during diastole, the balloon inflates and pushes blood up to the coronary so that it can better perfuse the coronary bed. And during systole, the balloon deflates and creates some suction effect, pulling blood down from the aorta into the rest of the body. So this is called counterpulsation, so that it syncs with the EKG and can inflate and deflate to make sure it's with systole and diastole. And this is a picture of what the catheter actually looks like on the bottom here. And once the sheath is in over a wire is what we put this catheter. And this here is the part that actually has the balloon, this part here. And like I mentioned, I did put a niche for each of these devices, and because the flow of this device is relatively low, we consider this device in mild cardiogenic shock, and because it could augment flow in the coronary bed, we think about using this device if we have slow coronary flow after a coronary interventions, and usually during acute coronary syndrome PCIs. Next is the Impella CP. It's a much more robust device. Instead of giving 0.5 liters per minute like the balloon pump does, this gives 3.5 liters per minute. But it comes with a big trade-off, and that's that the vascular access is much, much bigger. So if you remember, the balloon pump is 7 to 8 French, and the sheath size for an Impella is 14. So much, much bigger, double the size. The way that it works is this is the catheter that's pictured here on the left, and it's inserted through the femoral artery and is put over a guide wire inside the left ventricle. And there's a port here that sits inside the left ventricle that sucks blood up, and then it puts it through a motor, and it spits blood out here in the aorta. So it's moving blood from the left ventricle to the aorta, and it doesn't really matter what the ventricle is doing. It's moving that blood at 3.5 liters per minute. So it gives a lot of support. And the niche for this is it's really great for STEMI PCI. I think we've developed a lower and lower threshold for deploying this device in people who are having STEMI to optimize revascularization results and to keep patients stable during the procedure. It's also a device that we consider for moderate cardiogenic shock, so a little bit worse than what we would consider for a balloon pump, but not as severe as those that we'll talk about that are more robust devices that give even higher flow than this. So I call it temporary moderate cardiogenic shock that we consider this device for. Impella has since come out with a couple of more devices that function exactly the same way. They pull blood from the ventricle, spit it into the aorta, but they give more flow. And as you can imagine, which will be a theme with this, is that the more flow it gives, the bigger it is, and the higher the vascular risk from placing it. So the Impella V came out about 3-4 years ago, and as you can probably predict from the name, it gives 5 liters of flow, which is more than the Impella CP, which gives 3.5. Again, it comes at the trade-off of a bigger sheath. So the Impella CP is 14, this is 23. Again, works the same exact way, but because of how big the sheath is, it has to be inserted surgically through the use of a graft, which I'll show you some pictures of in a second so it's easier to understand. And what we use this device for is severe cardiogenic shock. This is basically replacement of full cardiac output. 5 liters per minute is almost full cardiac output. It does not give any support to the right ventricle, so the patient's right ventricle needs to be adequately contracting in order to use this device. We use it a lot of times when we expect prolonged recovery. And I'll talk more about why that is, and that's because of the way that it's implanted, which is surgically. So these are some pictures from the operating room of one time when we were implanting an Impella V. And this is Dr. Itagaki, who's one of the surgical colleagues I work with. This picture here on the left is him isolating out the axillary artery, which you can see right here. This is the axillary artery. And onto that axillary artery, he sews a graft. This is the graft, which is basically a big tube. And then inside that big tube can go a sheath, and then through that sheath can go an Impella. And this may seem like a small difference, but the vascular risk that comes from placing devices this way versus placing them percutaneously, even though it takes longer and is a bigger procedure, it's actually much, much safer when things are this big. And the other benefit to it is that it's in the upper body. And when devices are in the upper body rather than in the groin, patients can get up, patients can walk around, and this can really limit ICU complications, especially when there's going to be a prolonged recovery time. So this is a picture in our CCU of the first time we used an Impella V device, and this is actually on post-op day 1. So a patient went to the operating room, had the device put in, was intubated and in fulminant shock during that procedure, and within 24 hours was extubated and actually able to walk around. And as you can imagine, this really limits ICU complications and promotes the best recovery possible for this very, very sick group of patients. The Impella V, I think, Abiomed kind of threw the towel with making inventive names for these devices. Impella V does exactly what it sounds like it does. It gives a little bit more flow than an Impella V. It gives 5.5 liters of flow, and even sometimes 6 if you really turn it all the way up. What's interesting about this device, and what I think is very good about it, is that unlike the rest of the theme that we discussed, which the more flow, the bigger the sheath, this is actually more flow and smaller sheath. So it went from 23 French to 21 French. And in addition to a smaller French size, they improved the way that the device can be monitored in the CCU. So I know some of you are nurses here who have been working a long time in the CCU. You might remember that when we first started using these devices, we had to do echoes all the time to make sure the device haven't moved, to make sure that it's delivering adequate support in the proper place. In these newer devices, they have something called an optical sensor. This optical sensor can see where the device is relative to the aortic valve, and if the Impella moves into a wrong position, it will alert you. And similarly, when the device is not alerting you that it's in the wrong position, you don't have to do an echo and can be confident that it's in the correct position. So this is a really big advantage when it comes to ICU management. Tandem Heart is another device that we have that I'll say is probably the device we use the least common. It's a very difficult device to put in, and that's the reason that we use it least commonly. It does give a lot of flow. It gives 4 liters per minute, so somewhere in between the flow that you get from an Impella CP and the flow that you get from something like an Impella V. It does require both venous access and arterial access. So there is a venous sheath that goes in through the femoral vein that's pretty big. It's 21 French, and it goes in through the femoral vein, up the IVC, into the left atrium, and then punctured across the intraatrial septum so that its tip resides in the left atria. So that's the hard part about placing this device. You have to do a transeptal puncture and put a very large sheath across the intraatrial septum in a very sick patient. But if it works, this is the way that it looks. The cannula sits inside the left atrium, and it has a whole bunch of holes that drains blood from the left atrium. It comes out of the body, goes through a pump here, which pressurizes the blood, and then it reinserts it back into a cannula in the femoral artery. And this is usually a 17 French arterial cannula, so pretty big. So similar to the way that Impella works in that it's pulling blood from the arterial system and then delivering it distal to the aortic valve, except instead of pulling from the left ventricle, this is pulling from the left atrium. It is an effective device in those with severe cardiogenic shock, but because of how common Impellas are, because of how experienced we are with managing them in the ICU and how quickly we can place them, we rarely do this at this point, but in times where someone has had a recent aortic valve replacement, whether it's surgical or percutaneous, a lot of times we don't want to put wires and devices across that valve because it increases the risk of valve failure or even clotting. And in those situations is when we really consider this device, and it's the only time that we've used this device in the last 4 years is in the setting of recent aortic valve replacement. I'm going to mention briefly RV support devices. Prior to this point, we really only had devices that were able to support the left ventricle, and in the last 2 to 3 years, I think one of the most exciting things about mechanical support is that now we have percutaneous ways to support the right ventricle. And there's two main devices that we have that support the right ventricle. One is called Impella RP. It's a 23 French device that's deployed through the femoral vein. It's a very fancy catheter with a strange twist that enables it to be placed inside the right ventricle and go up into the pulmonary artery. And it has an inlet here that sucks blood up from the IVC-RA junction, puts it through a motor, and then pressurizes it and spits it into the pulmonary artery. So it's moving blood from the venous system past the pulmonary artery. It doesn't matter what the right ventricle is doing, so it's giving right ventricular support. A similar device that is more robust is called the Protect Duo. It's a cannula that's placed through the neck. It's very big. It's 31 French, and it works very similar to the way a dialysis catheter works. It has two ports. One is sucking blood out. One is putting blood back in. And the port that's sucking blood out is draining blood from the right atrium. And the port that's putting blood in, it's going distal to the pulmonic valve so that it could deliver mechanical support to the right ventricle. Despite it acting very similar to a dialysis catheter, just to give some numbers so you have some idea in your head, a dialysis catheter is usually 11 French, and this is 31. So it's much, much bigger, comes with a lot more risk of placing. So we have a high threshold to use it, but it's very effective at giving support when we need it. And the times that we use this is when someone's having a MI with right ventricular involvement, or probably the best time to use devices like this is after someone's gone to the operating room or to the cath lab, has gotten a device put into their left ventricle, which is giving adequate support to the left ventricle, but now we need to give a little help to the right ventricle, and both of these devices can do that. The last device I'll discuss is ECMO, and this is the most robust mechanical circulatory support device that we have that can be placed percutaneously. It can give up to 7 liters per minute of flow based on the sheath size that you select. And unlike the other devices that are, sort of one size fits all, this device, you can pick and choose what cannulas you use based on what patient you have. And based on what cannulas you choose, you define your risk profile of placement, and you also dictate how high you can flow the device. So the bigger you place, the higher you can flow, but the trade-off to that is that you have higher vascular risk in placing it. So the venous cannulas are very big. They're between 24 and 28 French in order to get adequate drainage of the venous system. And the arterial cannula is between 15 and 19 French. The venous cannula is inserted through the femoral vein, and under fluoroscopic control is placed up and sitting in the right atrium so that it can drain blood from the right atrium. And in addition to draining blood from the right atrium, there are holes along the cannula so that it can drain the entire IVC. So it gives very, very effective venous drainage. It comes out of the body. It goes through a pump that pressurizes it. And it ultimately is going back into the arterial system through the femoral artery. But you can't take blood from the venous system without oxygen and putting into the arterial system where you'd make the patient very hypoxic. So in this device, we use an oxygenator to add oxygen and remove carbon dioxide before it's sent back to the femoral artery. And the niche for this device is in severe cardiogenic shock that both ventricles are involved. Because it's draining the venous system, it's giving support to both the right and the left ventricle. Because we're using an oxygenator for patients that may have significant pulmonary edema and difficulty with gas exchange, this can help them by adding oxygen and removing carbon dioxide. And I think probably the most important thing that makes this device really facile and taking care of sick patients is that even though we prefer to place this under fluoroscopic control, it can be done at the bedside and it can be done quickly even if a patient has CPR in progress. So, it's a device that can really be used for rescue in and outside of the cath lab. I'm going to conclude with what I think is actually the most important point that I'm going to mention today. And what determines success in treating these very, very sick shock patients is highly effective critical care and procedural support in the cath lab and the CCU. And as a close mentor of mine taught me and says all the time, devices don't save patients, but rather they're a tool that help an expert team save patients. And I want to thank you all as the nurses and techs who really provide that expertise on our team that is what enables us to save these patients. So thank you all very much, and thanks for inviting me here today.